What if I say no and leave the meeting?
You're allowed to. Okay, so
But I feel like you're going to call me.
Yeah, absolutely I will. Okay, let me do my script.
Okay.
Professional.
Do you have to transcribe what I say right now?
Hopefully not.
Why?
Because
are you going to transcribe everything from now?
I'm going to transcribe it from a second from now. So.
Damn it.
Thank you for joining me today in this one-on-one interview. As you know, the aim of this interview is to hear more about your experiences within the domains of equity, diversity, and inclusion. Your participation in this interview is completely voluntary, and if at any point you would like to step out, take a break, pause, or end early, you are welcome to do so. The interviews are recorded only to generate transcripts, which will be anonymized. So if names are said, they will be taken out subsequently.
Are you going to transcribe your attitude and your tone?
Do you realize that's part of my transcript right now? This is showing up in my transcript. Know that. Do I have your consent to start?
Yes.
Before we get started, do you have any questions for me?
No.
Excellent. So for the records, could you please state your age, your gender, and your role at the Cancer Center?
I am 34 and a half years old. Sorry, what was the other part?
Your gender and your role at the Cancer Center.
I am a female, and I am a staff medical oncologist at the Jaravinsky Cancer Center.
Thank you. So the first question is me asking you to define some terms in sequential order. So we'll start with the first one. How would you define or explain to someone the term equity?
So equity, I think, sometimes gets confused for equality, where equality is everyone gets the same piece of the pie, whereas equity is trying to account for systemic differences or systemic deficiencies that some populations experience, and trying to ensure that everyone has access to the same opportunities.
All right. And then how would you define or explain diversity?
So diversity, I guess diversity can come in many forms, but having a multitude of different experiences, like life experiences. So that could either be different genders, sexual orientations, ethnicities. So being able to provide differing, opinions and life experiences.
Mm-hmm. And then lastly, how would you define or explain inclusivity or inclusion?
So inclusion.
I didn't quite catch that. Maybe I'll need you to speak up a little bit.
Yeah. So inclusivity, I think, is including all of those different experiences and not just, looking at what it has been traditionally the accepted view. And so being more mindful of including voices and experiences that may not have been excluded intentionally, but have not had the same opportunities.
Perfect. So keeping those definitions and ideas and themes in mind, do you see these domains influencing in any way the patient-clinician relationship or the interaction, and if so, in what ways?
Yeah, I think my experience with it really has been with more equity, I think, is a big one. So I think we try to provide the same care and try to, make sure that we're doing everything we can for our patients, that sometimes some populations just need extra time, the 15-minute follow-up clinic appointment is not enough for every single patient. Some of it is too much for some patients, and others it's not even close to being enough. And the need for resources also, they need more to have the same outcomes and to have the same success with treatment. So that's definitely one, especially in not just cancer care, but all of medicine. And then in terms of diversity, I think where I practice, there's less, I think, diversity in terms of the patient population. But when there is, I do notice it's been difficult, especially with the constraints of the system. So the time, the lack of resources, to be able to really dig in and figure out what the patient really needs. So some of that is that cultural competence and learning to speak not their language and like the technical term, but learning to speak or understand their nonverbal cues, because that may differ from what we're used to. So that, I think there's a lack of experience there, especially in where I practice. I've experienced it differently in other places like Mississauga, where you do need to kind of tap into that or spend more time, because it really impacts the patient-physician relationship. And then inclusivity, I think it matters. Are you asking more so for the patient-physician or?
Both ways.
Both ways. So inclusivity, I think it's been more of my experience in terms of leadership and my peers. So having more voices included, having a more diverse, physician pool kind of allows differing views, and then also priorities shift, I think, as well. And there's a bit more understanding of the competing, needs and competing issues that occur outside of work.
So exploring a couple of those things a bit more. So when you say that representation and leadership shift priorities, do you have examples of things that do shift, or things that aren't at the forefront because there is not that representation?
Yeah, I think, and this is more so from my conversations about promotion as well. So the focus on scholarship and what that looks like, I think, is shifting now as we've gotten more women in kind of higher positions and women in education. So, the priorities where it's not possible to have full day clinics and then to also devote your time to scholarship and like academics. I think traditionally, I think just women have had a bigger role at home. And so it is almost close to impossible to play both roles. And then with kind of more of a focus on mental health and balance, I think there's been a bit of a shift in terms of the promotion and scholarship to allow for other types of scholarship. So not specifically defined by publication, but, being able to evaluate or coming up with something innovative is not necessarily the only way to show scholarship, and to kind of do all of that with some balance in your entire life.
And what do you see as like the positive fallout or, trickle down benefit of that, either to the individual, to the division, or even patient care?
Yeah, I think there's less of a focus. I mean, there's still a focus on the end product, but I think it provides the patients with physicians who are less burnt out, or that's the hope. I don't know if that's what we're seeing yet, but, physicians who are healthier, who are potentially pursuing things they're passionate about and not really end product, and potentially things that, that may not be very sexy, but may actually still help patients kind of through their day to day. So I think that's interesting to look at as well.
And then earlier you mentioned how you have perceived a difference in the prioritization of these domains as it affects care between the current center and, say, somewhere like Mississauga. Like, what are the differences or anecdotally differences that you've encountered?
Yeah, so, my experience with Mississauga is it's a very diverse city. So almost every patient I met with was a visible minority from a different ethnic group, and so they have their own culture and kind of their own priorities and own values. And so I saw a lot more familial support, and that can be that can be good, but that can also be tricky, trying to navigate all those voices and making sure that the patient has a voice, but that it's also very helpful as well, kind of making sure that this patient has care. Mm-hmm. But then the other part of it, or the other challenge of it, is some of the cultures that were represented there are not very vocal or don't necessarily advocate for themselves. And I think they have a very traditional kind of, paternalistic kind of medicine, physician knows all. Mm-hmm. And so it's very hard sometimes to tease out what is important to them. And especially within oncology, having a goals of care conversation was extremely difficult. Mm-hmm. And I mean, I think that's a useful skill as a physician and oncologist to have, right? And to make sure that we have the resources and we're using the right language, where we're understanding their experiences properly, so we can have these conversations with them, because they do deserve to have these conversations and to be understood, especially when we're talking about end of life.
Yeah. What tools, or how do you reconcile the fact that, perhaps your training through the Western lens wants you to be engaging one-on-one with the patient, wants you to be really advocating for the patient to speak for themselves, or, from our trained perspectives, we want to have those very transparent discussions about end of life and goals of care. How do you bridge that gap when someone's cultural milieu isn't that?
Yeah, I mean, I think that's hard, but I can't sit here and kind of speculate without any experience. So I don't know if it requires like focus groups or meeting with representatives or having more representation in our allied health, like our social workers, having more resources where we can connect with the community itself, and with representatives who can kind of help kind of put together language or put together resources for these patients, or even have some, like, I think that's where diversity really matters here, is for a patient to see someone from their own culture or someone who understands their experiences to be part of the conversation. I think goes a long way, more than any, set of language that we can use for them.
And is there an example that comes to mind in oncology where that piece of connection, or that like very apparent point of empathy, really allowed for you to move forward with a patient encounter?
Yeah, I mean, I think this is like from my days as a resident, like doing an elective, but it was more so, with myself, I don't speak Tamil very well, but it was more so I was seeing a patient who is very, very resistant to coming into hospital. And like, she was elderly, 78. She was having an asthma attack, so it was needing oxygen. And her family was trying to convince her to stay. And I think, even me just speaking in Tamil, or kind of bringing up my experiences with my parents, she was able to understand where I was coming from. And they were kind of able to explain some of the reasonings behind the hospitalization and what her fears were. We were able to explore that. Mm-hmm. And I don't think that would have been possible if I hadn't kind of tried to connect with her. Mm-hmm. And, I'm thinking, what if she was a completely different culture? I don't think we would have had that success. I think it probably would have been an AMA, because we never would have gotten to the point of even exploring why she didn't want to come into hospital.
Mm-hmm. For sure. Now, as you reflect on your time now as a staff, and also as your time as a trainee, were you ever witnessed an encounter where someone else either engaged a patient very well and very successfully, incorporating these domains into that encounter, or very poorly, and that stood out in your mind?
I have to think. I think You're not going to use names, right?
No.
All right. So as a trainee, like there was that one patient who, as part of my longitudinal, would just like absolutely refuse to acknowledge that I was a physician. So my supervisor at the time actually came in, and I don't know how much of it was his kind of skills as a physician versus, their view of him, but he was able to engage them like wonderfully. Like he was able to listen to kind of, they went through the whole same, talk about their concerns and everything about chemotherapy. And I think he was quite clear, and he was like very understanding, and kind of talked about, because she was someone who spent half of the year in Pakistan, half of the year here. And so I think he didn't shy away from exploring her reasonings for that, and didn't shy away from being very blunt about why we would offer chemotherapy. And I mean, I was very early on in my training as well, and I think I was trying to be more of a people pleaser. Mm-hmm. And I already kind of sensed that, we didn't have a great relationship. So, but I think he was very understanding and gave them the time to speak, explored their reasonings, but then was also very blunt at the same time. And I don't think that had anything to do with him identifying. I don't think they're from the same culture, but I think it was just more his skill as a more experienced clinician.
Mm-hmm. And do you have any examples or anecdotes that come to mind where someone perhaps did not do so well and ran into roadblocks because there was not the willingness or ability to engage in that dialogue?
To be honest, I can't think of any. I mean, not specifically in terms of diversity. Like I've seen like some supervisors run into roadblocks just because there's a difference in communication style.
Okay.
Like I think like Goffin had, like, he's a little bit more sarcastic, but also tends to add a little bit of humor, and some patients respond very well to that, and it works wonderfully. It lightens the mood a little bit. But then I remember there was this one where it was a new consult. She was very, very anxious. The entire family was very, very anxious. And, I think there was some privilege there as well, but they were not appreciative of the tone. And it was very apparent within the room that they weren't. And I don't think he like stepped down either. I think it kind of
double down.
Yeah. As we know. And so, so they asked for a transfer of care.
Ooh.
Yeah. Which was surprising to me, because what he offered and what the physician who took on was the exact same care. It was just how it was communicated. Right. And it was, I just think that inability to read the room and understand what their needs were. So.
Fair enough. So then when you reflect back on this, at any point, either as a staff now, as a trainee in your fellowship or residency training, did you ever receive any formal training around EDI or these domains and how to incorporate those into your professional practice?
No.
Ever earlier on in training, say internal medicine or medical school, were you exposed to these ideas?
Yeah, I think in medical school, but again, in medical school to a lesser extent about diversity and inclusion. I think we had, what was a society in medicine, like stream in medical school in Ottawa, that I think once a week we looked at different aspects of medicine. So, specifically it was a lot about equity. So like about Aboriginal health, socioeconomic status, all of that. But I don't think at any point did we ever look into diversity or inclusivity.
have you had any opportunities to engage in informal training or teaching or just exposures in like your academic or professional career that you can think of?
Yeah, only when I listen to you do your presentation. Listening to grand rounds.
But beyond having talks with certain people, any other?
Listening to grand rounds.
Okay, don't get
the grand rounds. And then I attended, I don't know, what was it? The Kingston's grand rounds as well.
At my behest. But like seriously, like in terms of professional, ongoing, like, you know, continued medical education, through the university or through the JCC itself, have they ever offered you opportunities, especially given how, like, you know, part of the zeitgeist EDI is right now?
Yeah, I think there was one that was offered, like a seminar series, but I don't know. I didn't look into it further just because of the timing. It was like after work and it wasn't kind of well advertised. Yeah. So I didn't actually look at that. I think there was one where it was like a workshop in EDI.
Like clearly not mandatory, just like something people could engage with if they wanted to.
Yes, exactly.
And so when you think back in your own life, what opportunities or sort of what times were you sort of made aware or had to sort of reconcile with the fact that these domains matter to people, whether that was within your medical education or prior, earlier in life? When did it sort of come to the forefront of your mind?
I think it's been at the forefront since potentially internal medicine, or even earlier than that during clerkship. But I think really during internal medicine. So I did internal medicine in London, Ontario, and so yes, it is diverse, but really what the main issue there is just the substance abuse. And the socioeconomic status. So it is very clear to me that some of these patients needed more resources or needed a different method of communication. And we were actually doing them a disservice. And it wasn't until there was a palliative care doctor who actually specialized in treating substance abuse. And she did a few like half-day sessions for us in terms of the issue and then her approach to the communication. And it was very, very different. I think, you know, with some of how busy internal medicine can be, the medical side of things are prioritized. But by kind of ignoring these other issues, ignoring the social aspects of it and exploring that, we were actually doing them a disservice because they just kept bouncing back. And, you know, you can treat people with antibiotics all you want, but if you don't get to the underlying cause, it's just going to be further stresses on the system and on them.
Yeah. And so what are some things that have stayed with you? What sort of things, you know, really stand at the forefront of your mind that were discussed in that session that she had?
I think it was getting to the root cause as well. So the most important thing was kind of approaching patients without judgment. Because a lot of these patients, you know, were approached with, you know, very haughty, like, attitudes or just a lot of judgment, or what they said was not believed. And that causes them to shut down and it doesn't allow for any relationship to be built. And you can't get to the truth if they don't believe that you're there for their best interest. And so I think for her, it was always about building that rapport and having open communication, but without judgment. And that I think has been always the hardest part, is just the lack of time and really not having the life experiences to be able to relate and understand where they're coming from. And a lot of these issues were steeped in trauma. And that's not something someone is just going to share with the next person who comes in the room. And I mean, that happens a lot, right? With residents just rotating. It's not one person. And so that I think all of that, it's just way we practice medicine isn't always conducive to allowing us to build these relationships and, help these patients.
Yeah. So when you think about training and you think about, your recent life experience as a trainee and now on the other side as faculty, when we think about like trying to homogenize this in a way that can be distributed more broadly, how would you train people around EDI? Like, what are things that would work? What are things that wouldn't work based on your lived experience?
Yeah, I mean, I think a lot of it is exposure. So trying to have everyone exposed to different patient populations. But I also think education is really important. So one thing is being exposed to patients, and sometimes that's not possible. And sometimes not knowing what you're walking into is not always very helpful. So I think, I know it's hard with a lecture series and things like that, but even having like patient representatives coming in to academic half day to kind of talk about experiences, or when we're talking about substance abuse, what helps, like having counselors come in, having allied health and other healthcare providers coming in and kind of sharing their process and their experiences might be helpful. In terms of, and then, with social workers, knowing what resources are out there. I know like Oren did the kind of goals of care discussion, which is a very structured workshop, and that might be helpful as well. But I think it's hard because that is very, very specific. Whereas here we're running into many different scenarios. Hold on, I'm trying to think what else we could do.
Well, because the idea is like, how do you palatably and feasibly teach trainees about equity?
Yeah, but I think, also within internal medicine, like ensuring that your evaluations are not just focused on their medical knowledge, but also focusing on, their communication skills in terms of, or in these domains. Like, I know when I'm very, very, very specifically thinking of CTU, but you give your residents, you give your internal medicine residents the complex medical ones, and you give the other social ones. It's not as medically interesting. It's not going to build your skills. So I think that needs to be reevaluated, and that they need to see patients that are socially complex, even if they're medically stable.
I guess then the other question too is, now that we're in CBME and the paradigm of evaluation is very much, you have a scenario, you get evaluated for that encounter very specifically in real time. How do you incorporate evaluation of these learned domains in a CBME format?
Yes, that's so hard. I don't know.
Well, you're a coach. You're an academic coach. You've done evaluations.
Yeah. I mean, I think within CBME, I really think you need direct observation, and that's really, really hard. Like, it's one thing to say that, like from my experience as a coach, a lot of the things that I'm seeing are evaluations from other people and, information from the learner himself. But when I've actually witnessed in person, I see other things that aren't necessarily put on paper. And I think a lot of this is just like how we practice medicine, right? As a med student, you don't necessarily know how to treat a heart attack as a med student, and you're always going to go back and be, closely supervised. And I think that's kind of how we need to do it for this as well. And sometimes it's good for the staff to do this as well and have direct observation, because it's not like we experience all of these situations, and it's good to kind of have that exposure as well and to learn together.
So how would you, knowing the constraints of being a staff, how do you ensure that staff also have the adequate exposure and expertise to then turn around and evaluate trainees?
I don't know.
I
hate you. No, so I think, I think it's hard, right? I think unless you have a more robust, I think we need a more robust kind of allied health department, like with social workers or even counselors who have a bit more expertise, because I can't imagine that physicians will be able to become experts in this. And I think it really has to start much earlier on in med school. And I think the staff need to learn together with the learners. But I don't know if one or two courses or, grand rounds is going to provide people with enough experience and to be experts. So I wish I knew, but other than having support from people who already are experts and learning together, I think one thing that I was thinking of was like, how we do multi-D or like multi-D rounds, like do that, but like for allied health, right? Like you bring your complex social patients or patients who you are having a lot of difficulty with to these rounds, and you have access to these programs and people who may be able to help or actually move the resources around to help this patient.
Yeah, that'd be great. There is an understanding and an inherent bias that the individuals who are going to seek out opportunities to learn and to self-select and do those training modules in the after hours. How do you instead reach out and empower or encourage implicit buy-in from mid-career staff or people who don't necessarily have that intrinsic motivation already?
Yeah. So, I think it's a lot harder with mid-career, but I think if it's an academic position, then it's tied into your appointment. Right? Like there's lots of things that you have to do as an academic physician to hold your appointment. And I think tying that in more as a mandatory is probably the only way to get buy-in. And then hopefully there is enough there that intrigues them to continue on.
And what are roadblocks or concerns or reluctances that you anticipate people may bring up?
Well, I think like reluctance in doing this or having it be mandatory.
Any and all.
Yeah, I say this as like, make it mandatory, but then I would hate that because I think it's just a lack of time. And then there's also the just bandwidth, just the mental bandwidth, from a day to day of how much I can actually absorb. Because I don't, especially as an oncologist, you're constantly needing to keep up, and there's always some conference on the horizon, and you're needing to update yourself, and it's just a lot of kind of mental bandwidth to then have to absorb and learn a new skill, essentially. So, and I think especially in these times, which I'm sure you've heard a lot with COVID, I think there's just a lot of underdiagnosed or undiagnosed burnout. And I think that might be a driving factor or something that might be a big limitation.
For sure. Now, when you reflect in yourself, through all of your experiences and what you've learned along the way, how comfortable would you say you are when these domains are brought up? And what sorts of learning edges would you set for yourself as you look forward to the next 5-10 years of your career?
What do you mean by learning edges?
Like, are there things that you feel like you're not quite as comfortable with? Are there things that you wish you were better at? Are there things that you want to do more of?
So I think when this is brought up, I think I do have, I'm not that comfortable with it because I don't have as much experience as I wish I did. But I think my lived experience does make me a little bit more comfortable in that I feel like I can relate to some of these patients. Because I'm not from kind of the majority. And so even though I'm within medicine, I have had these experiences myself and with my parents. And so I am aware of the deficiencies within the medical community. So I think that's always helped me shape how I practice medicine. But there's lots of things I haven't seen. So I come from a visible minority, but, in terms of, differing sexual orientations or the trans community, I have no experience with that. And I think that's something I do want to open myself up to kind of understand their needs or their unique needs within medicine. Mm-hmm. And so I think that's something that I'd want to learn more about, but also learning more about different cultures and their kind of communication and their values as well.
Mm-hmm. And so you mentioned, your lived experiences and some of the things that you've been privy to just as a person going through life. In reflection of those lived experiences, are there encounters that come to mind where you have been on the receiving end of an interaction where someone did not acknowledge your, diverse or unique needs or where you were coming from, or made assumptions about you based on what they saw and didn't delve deeper into, that affected you personally or professionally?
I think not me personally. I've seen it with family. So, like I've had an uncle who was hospitalized for a STEMI, and and I was already in medicine at that time, but I think it shocked me to see the other side because, we're just rounding daily and we don't think about how we communicate or the lack of communication affects these patients, until I saw it with my uncle where he was supposed to be in hospital until his cabbage. And so he was deemed unsafe to go home. And then the physician on the weekend put in discharge papers. And my uncle was unable to, he wasn't being believed when he was saying, no, the surgeon saw me. He's like, well, there's no note from the surgeon. And, I don't think you know what you're talking about, and just put in the discharge papers, until he called me, and then the physician refused to speak to me. So he put me on speaker. And when I told him the surgeon's name, that's the only time he actually kind of paused, and then no communication, just canceled the discharge order and went on. So we had no idea what was happening, but this could potentially have harmed my uncle, right? But it was just that not believing him because he didn't speak very good English and didn't have the health literacy. Mm-hmm. So it really, and if I wasn't there, and not everyone has someone in their family in medicine, right?
No. So. And so that the advocacy piece of just, it's because they were inconvenient to you, you did do your due diligence.
Yeah, exactly. But it's also, if any other patient, it's not to be, but if any patient who spoke English well and was a bit more well-to-do, if they told you, no, the surgeon came and talked to me and was very you would listen to them and you'd be like, oh, okay, let me go check. But it was just, no, you don't know what you're talking about. Mm-hmm. That was very much the attitude towards him. Yeah.
That's horrible. That, truly, genuine.
Yeah. I don't know who this was, but.
And then in terms of your professional career, within your division or department, has there been any circumstances where, based on, say, your obvious identities of being a younger woman of color within the division, whether that's influenced either the roles or responsibilities you've been given or the manner in which things have been delegated to you?
I don't think it's crystal clear. I mean, I'm still quite new, so not a lot has been delegated to me. There's been things where I've been voluntold, but I don't think that has anything to do with my identity, more so, and it has more to do with just me being a new staff. I don't know how much, and I'm sure you've experienced it as well, but the respect for time, is something that I've struggled with through my training and now as staff as well. So that, I think, may have something to do with my gender and my age, because I don't necessarily see it happening with mid-career physicians, and there's certainly not with the men.
Mm-hmm.
And I think, I've also, and I don't know if you want me to go into this, but I've also had discussions with other female staff, who are more mid-career, and they've also experienced differing practices in patients who are referred to them. So patients who are deemed as more socially needy or socially complex are given or kind of preferentially referred to the female oncologist because we have this apparent skill set to be able to handle this.
And so it's like, how do you deconstruct those implicit biases that go into, say, that distribution, or that implicit, lack of understanding of your time being treated to the same value as, say, your older male counterparts? How do you deconstruct that?
What do you mean deconstruct? How do I handle that?
Well, how do you handle it personally, but also how do you see the system changing or evolving?
Yeah, I mean, I don't know how much of it is just because I've always been viewed as a trainee. But it's been difficult because you feel less than, and you don't feel like your time or you are being respected. So when your time's not being respected, you don't feel like there is any respect there for you. And to see that differential is even harder sometimes. And to be honest, I don't know how the system is going to change. I think I have tried to be a bit more vocal about protecting my time, more so than when I was a resident, where you don't want to rock the boat too much. So I think having this little bit of power has kind of helped. And I think maybe having more diversity in leadership and, having more women in leadership may be able to change as, what you feel is someone who is worthy of respect changes.
Yeah, for sure.
But that's going to take time. It's not something that happens overnight.
Absolutely not. And then the last question is there anything that we have not talked about over the course of this conversation that you want to discuss or say as it relates to the research question, which is understanding how oncologists learn about and understand the domains of EDI?
No, I don't think so.
Not a singular thought?
No. Do you want me to say anything?
I mean, it's up to you, right? Like, when you think about that, like, is there anything that, like, comes to mind?
I think it's going to be an uphill battle.
For what reasons?
Well, I think, one, I understand it to be a problem and avenue where we are severely lacking.
Mm-hmm.
And I think some of that is informed by my lived experience. But I think that's the very first step to kind of engaging in this, is acknowledging there is a deficiency, or acknowledging there is a problem. Mm-hmm. And I don't know how many people, I mean, I'm hoping everyone does, but I don't know how many people agree with that sentiment. Mm-hmm. Some may not because of lack of exposure. They just, just from their experiences. So I think that's going to be the biggest issue up front. Mm-hmm. And then, the second one is, even if we are able to create, or if we're able to create a program or create a education system, having engagement, I think, is going to be difficult, especially with all the stresses on the system and kind of increasing stress that falls on the physician's shoulders as other resources are being pulled away. Mm-hmm. So I think there's only so much time. Mm-hmm. So I think it'll need to be some kind of innovative way of education where it's built into the current education system. But I really, I think that's going to be a big challenge, is getting the practicing physicians to be engaged and invested in this.
For sure.
So it's about finding, leaders who are invested, who can kind of affect change and kind of drag everyone else around with them.
So top-down approach is what I'm hearing.
Yeah, probably.
Fair enough.
Well, I think it's going to be a bottom-up approach, right? Like, you start with physicians who have the time and the ability, and then, you want them to succeed and get into leadership positions, and then use that influence to affect further change.
Sure. Any other points?
No.
I'm not going to drag it out any further. I will stop recording then. And stop the recording.
Those are